So we will begin Chapter 21, Non-malignant disorders of leukocytes, including granulocytes and monocytes. So we know any types of changes in leukocyte morphology or concentration are really the body's response to various disease processes and certain toxic challenges. And most of the time, one of the cell lines is affected more than the other, which gives us a clue to a diagnosis. So let's get into some terminology here. So the first term that we're going to talk about is leukocytosis, because that's an increase of your total white blood cell count of over 11 times 10 to the 9 per liter. Now when we talk about leukopenia, that is an overall decrease in the white cells of less than 4.5 times 10 to the 9 per liter. Now this is in a normal adult, so you know that the reference range is between 4.5 and 11 as a normal range. Now let's talk about the factors affecting the neutrophil concentration, since it is most abundant of the white cells that would usually cause an increase or decrease in your overall white blood cell count. So some of those factors include the bone marrow production, because we know all of the hematological cells are produced in the bone marrow. So if they're producing too much or not enough, that will lead us to a condition as well. The rate of egress to tissue. So we know that neutrophils' job is to go into tissue and fight off bacteria. So that could lose the vasculature neutrophils and go into the tissue to cause a decrease in your peripheral neutrophil count. Now as well, we'll talk about some quantitative changes that affect the ratio of marginating to circulating neutrophils. Now half of the neutrophils are just waiting and stuck onto endothelial lines in your periphery, waiting for a stimulus to go into tissue to act. And only half of these, the other half of the neutrophils, are in the circulation going around the bloodstream throughout the body. So any kind of effect in that aspect will change the ratio and cause your peripheral PMNs to go up. So first we're going to talk about the quantitative disorders that happen with neutrophils. Now they can happen as a cause of a malignancy, but we're not going to talk about that in this chapter. We'll continue with that chapter in a few weeks. Right now we're going to talk about the benign kinds of conditions and disorders with neutrophils that causes a quantitative change, an increase or decrease in the number of neutrophils within the peripheral circulation. Okay, so let's first talk about immediate neutrophilia. So we did say that 50% of those neutrophils are free-flowing in the vasculature, and 50% of those are stuck to the endothelial wall here. So sometimes when there's an extreme stimulus, such as anesthesia, epinephrine, or extreme exercise, the ratio of these cells could be disrupted and enter into the circulating pool. So really, this is immediate and it only lasts for about half an hour. So if a blood draw is taken after these kinds of situations, you might see an increase in your CBC. However, there's no actual change in the number of neutrophils within the vasculature, and the increase in circulating neutrophils are mature and normal, and not really a cause for concern. When we talk about acute neutrophilia, this occurs when neutrophils egress from the bone marrow storage pool into the peripheral blood, usually following some kind of pathological stimulus, sometimes as a bacterial infection or a toxin. Now here you can see the neutrophil count increase as much as 10-fold. Now this happens a few hours after encountering the bacteria, so you may see the bone marrow start to spit out bands and those immature cells just to get to the tissue to fight off these bacteria. Now, if this acute situation doesn't resolve and goes into a chronic neutrophilia, which usually happens if the stimulus goes beyond a few days, This results in the complete depletion of the bone marrow storage pool and increased production of neutrophils within the vasculature. Now here you might see an increase of immature granulocytes coming into the bone marrow, such as myelocytes and metamyelocytes. When this happens, this is considered a left shift. So from this condition, usually from a bacterial toxin, the white blood cell count will not go above 50 times 10 to the 9 per liter. So not only does this left shift or Leukemoid reaction result in an increase or quantitative change within the neutrophil count, which leads to an increase in the total white blood cell count, we also start to see some changes, qualitative changes within the cytoplasm of the neutrophil. And you're also starting to see a left shift. So the bone marrow is starting to release these immature types of granulocytes. So you have metamyelocytes, you have some bands, and then you have some mature neutrophils, but you start to see the cytoplasm has those granules which are darker and they look toxic because they're trying to respond to killing certain types of bacteria such as strep and staph. And also you'll see Dolly bodies. Another classic symptom or sign cytoplasmically is vacuoles within the neutrophil. And we'll talk about that a little bit more in the qualitative changes within the neutrophil. So besides a leukemoid reaction or instances with severe bacterial infections, there are causes of neutrophilia that are not caused by bacteria, such as tissue destruction or injury, which can result from an increase due to tissue necrosis or certain metabolic conditions, drug intoxication, as well as a physiological leukocytosis, which happens at birth. And for the first few days of life, you have a leukocytosis accompanied by a left shift in newborns. Similarly, if patients have stimulated bone marrow states and are getting corticosteroid therapy or any kind of growth factor stimulation where you can increase the neutrophil count as well. So now we're going to talk about neutropenia. So it's only classified when the neutrophil count drops below 1.5 or 2 times 10 to the 9 per liter. Now when you consider a decrease in neutrophils, you're thinking of either there is increased cell loss, decreased production, or a difference in the ratio of margination. So let's talk about the neutropenic causes caused by decreased bone marrow production. So in this case, the bone marrow normally has a myeloid to erythroid ratio of 3 to 1. So you have 3 myeloid cells to 1 erythroid cell within the bone marrow. Now when you have a decreased bone marrow production, your ratio of myeloid to erythroid cells will decrease, either 2 to 1 or 1 to 1, and in very rare instances, you have a 2 to 1 erythroid myeloid ratio as a substitution. Now, just as we saw in chronic types of neutrophilia, that we have an increased production of neutrophils going out of the bone marrow due to some kind of bacterial stimulus. Now, if this isn't resolved over time, the bone marrow will not be able to keep up with it and start to shut down. And in that case, the bone marrow will not be able to produce enough cells, and you will have a neutropenia, leading to an inadequate response to inflammatory sites, which can result in increased risk of overwhelming infections and can lead to patient death. Now, there's also a wide variety of drugs and chemicals associated with leukopenia that, if given in certain drugs, chemotherapy, and radiation treatments for cancer, will also cause a pancytopenia. Now, we also talked about some stem cell disorders last semester, such as aplastic anemia, that also leads to the decrease in white cells. And we talked about megaloblastic anemia as a condition for abnormal defects in the red cells, but also affects the nucleus of the white blood cells as well, and the body will not recognize these cells as normal and destroy them. Now, increased cell loss could also be a cause of neutropenia because there's certain types of viruses, bacteria, and protozoans that induce tissue damage, which also increases the demand for and the destruction of neutrophils. There's also an immune type of neutropenia where there are antibodies directed against neutrophil-specific antigens that cause a decrease in the number of neutrophils. Now here, these cells are destroyed in a manner similar to how red cells were in immune hemolytic anemia we talked about last semester. Into categories of alloimmune, where maternal antibodies are directed against paternal origin antigens in fetal neutrophils and then transferred across the placenta, or autoimmune neutropenia, which is either primary or secondary and can occur with other diseases, prominently in young children. So you can also have a neutropenia that is false or pseudo because the ratio of marginating neutrophils along the vasculature increases due to some kind of hypersensitivity reaction. Or you can have a complete false neutropenia, which is a lab artifact, because a lot of the times here you see that the neutrophils are sticking together and the instrument does not verify that they are there. And in this case, you need a sodium citrate type of specimen to not have these cells stick together. So now we're going to discuss the qualitative or morphological abnormalities seen in neutrophils that are not usually picked up by the hematology analyzers, but these are either nuclear or cytoplasmic problems that you as a CLS must pick up and identify within the morphology. So the first condition we're going to talk about is Pelger-Huey anomaly. It's a benign inherited autosomal dominant type of condition which occurs in 1 in 5,000 individuals. Here you see the neutrophil nucleus does not segment beyond 2 lobes or can appear as a single round nucleus with no segmentation. Now the other nuclear abnormality would be hypersegmentation, where you have larger than normal neutrophils with 6 or more nuclear segments, which is an early indicator of megaloblastic anemia, usually caused by folate or vitamin B12 deficiencies, as seen in Chapter 15 last semester. Now we're going to talk about the cytoplasmic abnormalities seen in neutrophils and are often found in infectious states, and when present can include diagnostic information. So it's very important you pick this up as a CLS. So the first type of inclusion we're going to see are Dolly bodies. So the arrow is pointing to one, and these are light grayish blue inclusions in the cytoplasm of neutrophils and can be found in eosinophils as well. They're usually at the periphery of the cell and are composed of aggregates of rough endoplasmic reticulum. So here they're seen in severe types of infections, burns, and a result of toxic drugs. Now the second type of cytoplasmic abnormality would be toxic granules. Here you see large, deeply stained blue primary granules in the cytoplasm of segmented neutrophils and sometimes in bands and metamyelocytes. So normally the primary granules lose their basophilia as the cells mature. So even though about 1/3 of the granules remain, their presence is not really detectable. But if they're toxic, they remain basophilic as they mature because they lack the maturation and they're discharged to fight bacteria. So you can also see that there's a Dolly body in the bottom corner here, and a lot of the accompaniment with this toxic granulation, you can also see toxic vacuolation or vacuoles within a neutrophil. And similar to monocytes, they're clear, unstained circular areas, and the vacuoles are probably represent the end stage of phagocytosis. Some of the times you can see intracellular microorganisms, and here you can see a large variation of cytoplasmic vacuoles. Now, there are also inherited functional types of abnormalities within the neutrophil, and it's suggested that these abnormalities be suspected if patients have recurrent types of severe infections, abscesses, or any kinds of delays in wound healing and antibiotic resistance. So the types of inherited benign conditions we're going to talk about is Alder-Riley anomaly, Chediak-Higashi syndrome, May-Hegglin anomaly, chronic granulomatous disease, myeloperoxidase deficiency, and leukocyte adhesion deficiency. The first condition, Alder-Riley anomaly, is an inherited condition that is characterized by the presence of large purplish granules in the cytoplasm of all leukocytes. So this is different than toxic granulation, which is only in neutrophils. And here the cells function normally. This condition is associated with a mucopolysaccharidosis, such as a Hunter's or Hurler's types of syndrome, which are both lysosomal storage disorders. And we'll talk about what that is with the monocyte condition. The next condition is Chediak-Higashi syndrome, which is a very rare autosomal recessive disorder. It can lead to death in infancy because of the recurrent bacterial infections. So here you see the giant gray-green peroxidase bodies and giant lysosomes found in the cytoplasm of these leukocytes that are causing the granules not to work. So they can engulf the microorganism, but they cannot kill it. And these are also seen in lymphocytes as well. The next condition, May-Hegglin anomaly, is rare inherited autosomal dominant trait in which the granulocytes contain these inclusions consisting mainly of RNA from rough ER, which are similar to the appearance of Dolly bodies. So here the cells also function normally, but there are bleeding tendencies associated from thrombocytopenia, and you have an image with an arrow showing a very large platelet. And patient tendencies are likely to have a low platelet count. The next type of inherited functional abnormality is chronic granulomatous disease, which is an inherited X-linked disorder characterized by defects in the respiratory burst oxidase system. Now here patients suffer recurrent and life-threatening infections by bacteria and fungus, and it's diagnosed in childhood, but sometimes it can be diagnosed in early adulthood. Now I didn't show you a picture of a neutrophil here because the cells affected by it are morphologically normal. So they have a defective respiratory burst. They can engulf the microorganisms, but again, they don't produce the hydrogen peroxide to kill the microorganisms. Myeloperoxidase deficiency is a benign autosomal recessive disorder characterized by the absence of myeloperoxidase in the neutrophils and monocytes. So here they have a deficiency, so they can't adequately kill microorganisms. However, neutrophils are able to utilize an alternate antimicrobial system to kill these microbes, and the cells can function normally. Leukocyte adhesion deficiencies are rare autosomal recessive types of abnormalities where there's absence of cell surface adhesion proteins that affect multiple cell functions, but the morphology looks normal. So it's a serious condition that has recurrent infections and can have high mortality rates. So when we start talking about the conditions associated with eosinophil or basophil disorders, they're very rare because the lower limit of these reference intervals is very low. So a decrease is really difficult to determine and probably not significant. With eosinopenia, we can see it in acute infections and inflammatory reactions with the administration of glucocorticosteroids. Now, an increase in eosinophils can be potentially a serious condition and usually identified as a count of greater than 0.4 times 10 to the 9 per liter absolute eosinophil count. And a basophilia refers to an increase in basophils of greater than 0.02 times 10 to the 9 absolute count. Here is an image of hypereosinophilic syndrome. All the cells here are mature, and you're seeing some vacuolization. You have to distinguish between the clonal type of an eosinophilic leukemia that usually presents with immature granulocytes as well. Now here is a picture of a patient with CML, so chronic myeloid leukemia, which usually has an increase in basophils. But basophilia can also be seen in immediate hypersensitivity reactions. So quantitative disorders of monocytes are usually considered with an absolute count of greater than 0.8 times 10 to the liter, whereas qualitative disorders we're going to discuss also include tissue macrophages. But here you can see many monocytes in this picture that is often seen with inflammatory conditions and again certain types of malignancies or after recovery stage of an acute infection as they play an important role in cellular response and cleanup. So the qualitative disorders of monocytes include a large group of inherited conditions which usually results in either a mucopolysaccharidosis or lipidosis. So Gaucher's disease, an inherited autosomal recessive disorder characterized by a deficiency in beta-glucosidase, the enzyme needed to break down lipid, glucocerebroside. So in this disease, the macrophage is unable to digest the stroma of ingested cells, so lipid accumulates. So here you're seeing Gaucher cells that can be found in the bone marrow of individuals with this type of condition. So Niemann-Pick disease includes a group of rare disorders that are related to autosomal recessive diseases and result in infancy poor development. Here the spleen and the liver are greatly enlarged and the disease is often fatal by the age of 3. So in this disease you have a deficiency of a sphingomyelinase, an enzyme that breaks down lipid, resulting in excessive sphingomyelin storage. So you see this macrophage has a foamy appearance, which you need to know for your board exam. C-blue histiocytosis syndrome is a rare inherited disorder characterized by an enlarged spleen and a decreased platelet count. If you can see, these macrophages are C-blue staining laden with lipid and are found in usually the liver, spleen, and bone marrow. The cells are very large in diameter and have a dense eccentric nucleus, and the cytoplasm contains blue or green granules.